Welcome to a new episode of Evidence Echo.
You know that feeling when you uncover something really important, something that's kind of been hiding in plain sight?
Mm-hmm.
It's a silent health threat, really. A hidden danger that's escalating pretty rapidly across continents.
Yeah, it really is.
We're talking about non-alcoholic fatty liver disease, or NAFLD. And specifically, its surprising and growing impact, especially in places like Africa, the Middle East, and Asia.
Right.
So our mission to, really unpack what an NAFLD truly is, why it's become such a pressing issue, and what the latest research tells us about its implications. Big implications for health systems and, frankly, millions of lives.
Absolutely. Think of this as your shortcut to understanding a health crisis that, like you said, isn't maybe grabbing the big headlines, but is definitely reshaping healthcare behind the scenes. And we've pulled together insights from, well, a stack of crucial sources for you. We're looking at epidemiological studies from places like Global Health, Epidemiology and Genomics, Gastroenterology Research, and also key data from the Global Burden of Disease study. So lots to get into.
Great. So let's start right at the beginning then. What exactly is NAFLD?
Okay, so at its core, NAFLD is defined as having fat buildup in the liver. The medical term is hepatic steatosis.
Hepatic steatosis.
And this is really the key part. It's without excessive alcohol intake. It's not caused by drinking too much alcohol.
Okay, so that non-alcoholic part is crucial.
Very crucial. And it's not just one single thing either. It's more like a spectrum of conditions.
A spectrum, how so?
Well, on one end, you've got simple steatosis. That's basically just fat in the liver cells.
Mm-hmm.
And typically this follows a more benign course. It doesn't usually cause major problems on its own.
Okay, so just fat, but it can get worse.
It can. And that's where the stakes get higher. The more severe form is called non-alcoholic steatohepatitis, or NASH.
NASH, heard of that.
Right, so NASH isn't just fat. It's fat plus inflammation. You actually get inflammatory cells invading the liver tissue.
Ooh, that sounds more serious.
It is, because NASH has the potential to progress. If it's not managed, it can lead to fibrosis that's scarring of the liver.
Scarring.
And that scarring can eventually become cirrhosis, where it's extensive and basically irreversible.
And cirrhosis is really bad news for liver function?
Definitely. And on top of that, NASH also significantly increases the risk of hepatocellular carcinoma, that's liver cancer.
Wow. So fat, inflammation, scarring, cirrhosis, cancer risk. That's quite a progression.
It is. Now, this progression, it's usually slow, often spanning many decades. But NASH is now regarded as a major cause of liver cirrhosis globally, and it's definitely linked to higher overall mortality and specifically liver-related death. So even if it's slow, the outcome can be very serious.
And what makes it particularly tricky, I gather, is the symptoms or lack thereof.
Exactly. That's the really insidious part. Most people with NASLD, even NASH sometimes, have very few symptoms, if any.
Really? Nothing?
Well, they might complain of just general fatigue, maybe feeling a bit unwell, malaise, or perhaps a dull sort of ache in the upper right part of their abdomen. But things like jaundice, yellowing of the skin or eyes, that's actually quite rare in the early stages.
So often goes completely unnoticed then.
Very often. It frequently gets diagnosed almost by accident, following abnormal liver function tests that pop up during routine blood work for something totally unrelated.
Ah, okay. So someone goes for a checkup, gets blood tests, and suddenly there's a flag about their liver enzyme.
Precisely. Which then prompts further investigation. Now, diagnosing it definitively and figuring out how severe it is, well, that could be a challenge.
How so? What are the options?
The gold standard, technically, is a liver biopsy, where they take a tiny sample of liver tissue.
Right.
That lets you see the fat, the inflammation, the scarring directly. But, it's invasive. It carries risks, bleeding, infection, pain, and it's just not practical or cost-effective for screening large numbers of people.
Makes sense. You can't biopsy everyone with slightly off liver tests. So what else?
Well, non-invasive methods are much more common for initial assessment. Ultrasound is used a lot.
Like a regular ultrasound?
Yeah. It can show the fat in the liver. It's relatively cheap, widely available, so it's considered pretty ideal for, say, resource-poor settings.
But are there limitations?
Yes. The main one is sensitivity. It's not great at picking up milder cases of fatty liver. And just looking at those elevated liver enzymes in blood tests, they lack sensitivity too. Many people with NAFLD have normal liver enzymes.
So you could miss cases with just blood tests or even ultrasound sometimes. What about more advanced imaging, like MRI or CT scans?
They can be used, and they're often more accurate, but they're much more expensive and not as accessible everywhere, so not really feasible for large-scale screening either.
So this seems like a real diagnostic hurdle, especially if you're trying to understand how widespread this is in a population.
It is. And that's where another non-invasive technique has become quite attractive, especially for research and larger studies. It's called transient elastography, or TE. You might know it by the brand name FibroScan.
Ah, FibroScan, yes. How does that work?
It uses ultrasound technology, but it measures liver stiffness. Stiffness is a really good surrogate marker for fibrosis, for scarring.
Okay, so it measures the scarring.
Indirectly, yes. And many TE devices can also quantify the amount of fat in the liver at the same time using something called the CAP score. Plus, a big advantage for large studies is that the data collection is pretty operator independent.
Meaning you get consistent results regardless of who's doing the test.
Largely, yes. Which makes it much more efficient and reliable for collecting data across big populations compared to, say, operator-dependent ultrasound assessments.
Okay, so TE is a valuable tool for getting a better handle on prevalence and severity without biopsies.
Exactly. It's helping us understand the scale of the problem much better.
All right, so we've established NAFLD as the spectrum of liver conditions, often silent, linked to serious outcomes, and tricky to diagnose easily. Let's zoom out now. What does this silent danger look like on a global scale?
Well, the estimates are pretty sobering. Globally, it's thought that roughly 1 in 4 adults has NAFLD, so prevalence is hovering somewhere between, say, 25% and 35%. It's huge.
A quarter of the world's adults, wow. Are there regional differences?
Yes, definitely. If you look at the breakdown, Asia and Europe tend to be around 23, 24%. North America is similar, maybe mid-20s. But then you see higher rates in the Middle East and South America, closer to 30, 32%.
Okay, so higher in the Middle East and South America. What about Africa?
Africa is interesting. The big meta-analysis reported the lowest prevalence there, around 13.5%.
Lowest. That seems counterintuitive given some of the risk factors we'll probably discuss.
It does. And it's really crucial to emphasize that this 13.5% figure is almost certainly a significant underestimate.
Why do you say that?
Because that particular meta-analysis, despite being large overall, only included 2 studies from the entire continent of Africa. And both of those had small sample sizes.
Only 2 studies. That's not much data to go on for a whole continent.
Exactly. It highlights what researchers call a critical dearth of data from proper population-based studies in Africa. Without that data, it's incredibly difficult to reliably figure out the true prevalence and what health services are actually needed there. We just don't have the full picture yet.
So the African number is likely much higher in reality. We just lack the studies.
That's the strong suspicion, yes. And this lack of data is a problem in itself. But even with the data we do have globally, there's another alarming trend emerging.
What's that?
Well, if you look at the period between 2009 and 2019, NAFLD wasn't just, present. It was the most rapidly growing contributor to serious liver complications worldwide.
Most rapidly growing. Compared to what? Hepatitis C, alcohol.
Compared to other major chronic liver diseases, yeah. We're talking about cirrhosis and liver cancer, specifically caused by NAFLD researchers, often called as LC-NAFLD.
LC-NAFLD, okay.
The global incidence rate, the number of new cases each year of LC-NAFLD, increased at an annual rate of plus 1.75%. Compare that to other chronic liver diseases, which increased at only plus 0.41% per year.
Wow, that's more than 4 times faster.
Exactly. And you see similar, really concerning trends for death rates due to LC-NAFLD. They went up plus 1.54% annually, while deaths from other liver diseases barely changed, maybe plus 0.07%.
And what about the overall burden, like disability?
Same story. Disability-adjusted life years, or DALYs, which measure lost years of healthy life, increased by plus 1.14% annually for LC-NAFLD.
Yeah.
But for other chronic liver diseases, DALYs actually decreased slightly by 0.47%.
So while we might be making some progress against other liver diseases, NAFLD is accelerating rapidly in the wrong direction, causing more cases, more deaths, and more disability.
That's the clear picture the data paints. It's not just a background issue. It's actively getting worse, faster, than other liver threats on a global scale. It shows a really concerning trajectory for you, the listener, to grasp.
Okay, that's stark global trend. You mentioned earlier that Asia and the Middle East seem to have higher prevalence. Does this rapid increase in complications also hit those regions hardest?
It does, very much so.
Yeah.
Let's zoom in on Asia and the MENA region, Middle East, and North Africa. The burden there is really substantial.
How substantial?
In 2019 alone, Asia accounted for almost half, 48.3% of all global new cases of LC-NAFLD. and 46.2% of all global deaths from LC and NAFL.
Nearly half the global burden just in Asia.
Yeah, we're talking about over 83,000 new cases and nearly 78,000 deaths in Asia in just that 1 year. And the MENA region contributed significantly to around 8.9% of global incidents and 8.6% of deaths. That's another 15,000 cases and 14,000 deaths.
Those numbers are staggering. And are the trends worsening there too?
Even more starkly, yes. Between 2009 and 2019, almost every single country in Asia, 32 out of 34, saw a worsening trend in the incidence rate of LC-NFLD. And in the MENA region, all 21 countries experienced a worsening trend.
Every single country in MENA saw rising rates of severe liver disease from NAFLD.
Every single one, according to this data. And if you look at the actual rates per 100,000 people in 2019, Central Asia, East Asia, Southeast Asia, and the MENA region all had incidence rates for LC and AFD that were noticeably higher than the global average.
Are there specific countries driving these high rates?
Yes, the data points to some key areas. India, for instance, saw a very significant annual increase in its LC-NFLD incidence rate, about plus 4.7%. In the MENA region, countries like the United Arab Emirates showed a massive jump, plus 8.31% annually. Syria and Sudan also saw rates climbing fast, over 5–6% per year.
Wow, 8% annual increase in the UAE. That's incredibly fast.
It is. And then you have countries like Mongolia, Thailand, Egypt, Kazakhstan, Cambodia. Their actual incidence rates were particularly high, exceeding 4 cases per 100,000 people, which is double the global average.
And you mentioned earlier that NAFLD complications were rising faster than other liver diseases globally. Is that pattern seen in these regions too?
Even more pronounced in some places. Get this. In countries like Myanmar, China, Afghanistan, and Pakistan, the incidence rate of LC-NFLD worsened more than 3 times faster than the rate for other chronic liver diseases.
3 times faster. It's like NAFLD is just taking over as the dominant driver of severe liver disease in these areas.
It certainly looks that way. And another really concerning finding, especially in the MENA region, is who is being affected.
What do you mean?
The age-specific death rate attributable to LC-NAFL actually increased specifically among younger adults, those aged 25 to 59 years. It went up by about plus 0.34% annually in that age group.
So it's not just affecting older people, it's increasingly causing deaths in people during their prime working years in MENA?
That's what the trend suggests, adding another layer of urgency to this.
Okay, rising incidence, rising deaths affecting younger adults. But then there was something puzzling in the data for some MENA countries, right?
Yes, this is quite interesting. Some countries, specifically Oman, Kuwait, and Afghanistan, actually showed improving mortality trends for LC and AFLD. Their death rates seemed to be going down, even though their incidence rates, the number of new cases, were going up.
Wait, how does that work? More people getting the severe form, but fewer people dying from it? That seems contradictory.
It does seem contradictory, and it raises a big question. Why? What's going on there?
Is it better treatment, better healthcare access in those specific countries?
That would be the optimistic explanation. But the researchers speculate that might be something else, potentially more concerning.
Which is?
A lack of awareness among healthcare providers. It's possible that NAFLD isn't always being correctly identified and recorded as the underlying cause of death on death certificates.
So people might be dying from cirrhosis or liver cancer that was originally caused by NAFLD, but it gets recorded as something else, or just liver failure.
Exactly. If there's underreporting of NAFLD as the root cause, it could artificially make the mortality trends look better than they really are, especially while the actual number of people getting sick, incidents, is climbing. This might be particularly relevant when you consider the data quality scores for cause of death reporting in some of these regions, according to the Global Burden of Disease Study methodology.
So this improvement might actually be masking the true worsening impact because of diagnostic or reporting issues.
It's a strong possibility that needs further investigation. It really underscores how crucial awareness and accurate data collection are. If you don't know the true cause, you can't effectively target the problem. It makes you wonder, doesn't it, what other health trends might be hidden by similar data issues?
Absolutely. It shows the limitations of relying solely on reported mortality data without considering the context. Okay, so we have this massive accelerating global problem hitting Asia and MENA particularly hard. What's actually driving this epidemic?
Well, the strongest links are clear and well established now. NAFLD is widely considered the hepatic component, basically, the liver's part of metabolic syndrome.
Metabolic syndrome, that collection of issues like obesity, high blood pressure, high blood sugar, abnormal cholesterol.
Precisely. And so the rise of NAFLD is very closely tied to the global pandemics of obesity and type 2 diabetes mellitus, T2DM.
Okay, let's break that down. How strong is the link with obesity?
It's incredibly strong. Estimates suggest that up to 80%, 0% of individuals classified as obese also have NAFLD.
Wow, 80%.
And if you look at people with severe obesity, the kind who might undergo bariatric surgery, the prevalence can exceed 90%. And maybe up to 5% of them might already have undiagnosed cirrhosis at the time of surgery.
Undiagnosed cirrhosis, just discovered during surgery for obesity. That's scary. What about diabetes?
The link is just as stark. In patients with type 2 diabetes, the prevalence of NAFLD is significantly higher than in the general population. Global meta-analyses put the figure around 54%.
Over half of people with type 2 diabetes likely have fatty liver disease.
That's the estimate. And even in Africa, where we have less population data, specific clinic-based studies focusing on T2DM patients show these high rates. One study in Sudan found 50.3%. Another in Ethiopia reported 73%.
So obesity and diabetes are clearly major drivers. But I remember reading something about ethnic or racial disparities that aren't fully explained by just obesity and diabetes rates.
Yes, this is a really fascinating and complex area. There's this observation that certain ethnic groups, notably African Americans in U.S. studies, tend to have a lower prevalence of NAFLD compared to, say, Hispanic or white populations.
Lower prevalence, even if they have similar or even higher rates of risk factors like obesity or diabetes.
Exactly. Even when they carry a greater burden of those traditional risk factors. And this isn't just in the U.S. A study in South Africa looked at women and found that African women had lower amounts of liver fat compared to women of other ancestries, despite having higher total body fat, higher BMI, and larger waist circumferences.
So they had more overall fat and belly fat, but less fat in the liver. How could that be?
It's a puzzle. And the leading hypothesis right now revolves around where the body stores fat, the distribution of adiposity.
Okay, tell me more.
The speculation is that subcutaneous fat, the fat just under your skin, the stuff you can pinch, might actually be somewhat protective.
Protective? How?
It might act like a buffer, soaking up circulating fats, triglycerides, and preventing them from flooding the liver. But visceral adipose tissue, that's the deeper fat packed around your internal organs, seems to do the opposite.
The dangerous belly fat.
Right. Visceral fat is metabolically very active and seems to promote the liver making its own fat, a process called hepatic lipogenesis. So the theory is that some ethnic groups might naturally store fat differently, perhaps more subcutaneously and less viscerally, which could offer some protection against NAFLD even if their overall body fat is high.
That's really interesting. So it's not just how much fat, but where you store it that matters for liver health.
It seems increasingly likely that fat distribution plays a crucial role, though more research is definitely needed to fully understand these disparities.
Beyond these metabolic factors and fat distribution, what about lifestyle, diet, exercise?
Absolutely critical. Studies have drawn strong correlations between LC and AFLD, the severe form, and specific behavioral risk factors, even after adjusting for socio-demographic factors.
Okay, what kind of lifestyle factors? Let's take Asia first.
In Asia, significant links were found with dietary risks. Think diets high in red meat, high in sodium, high in processed foods, but low in protective things like legumes, fiber, fruits, polyunsaturated fats, and seafood omega-3s.
So a typical westernized diet pattern, maybe?
It seems that way, yes. Also, other metabolic risks like high blood pressure, high BMI, high LDL cholesterol were key. And interestingly, tobacco use was also significantly linked in Asia. The analysis showed even a modest 10-point increase in a dietary risk score was associated with a 7% increase in LC and FLD incidence.
A direct link between poor diet score and higher rates of severe NAFLD. What about the MENA region? Similar factors?
Similar, but with slightly different emphasis sometimes.
Yeah.
In MENA, low physical activity was a major correlated factor.
Lack of exercise.
Right. Plus, again, a range of metabolic risks. High BMI, kidney dysfunction, which we'll touch on later, high fasting blood sugar, and dietary factors like high intake of processed meat, sugar-sweetened beverages, red meat again, and trans fatty acids. High blood pressure and high LDL cholesterol were also significant.
Sugar-sweetened beverages, that's a big one, often cited.
Yes. And in MENA, a 10-point increase in the metabolic risk score was associated with substantial increases across the board of 5.5% higher incidence of LC-DEV-LD, nearly an 8% higher death rate, and over a 7% higher daily rate.
So these lifestyle and metabolic factors aren't just abstract risks. They translate directly into higher rates of disease, death, and disability from NAFL in these regions.
Precisely. It paints a very clear picture. This isn't just happening to people, it's strongly linked to how people are living, eating, and moving, especially in the context of these rapidly changing societies. Okay, so we've established that AFLD is driven by metabolic issues linked to lifestyle and has complex interactions with ethnicity and fat storage. But you mentioned earlier it's a multi-system disorder. What does that mean? It's not just about the liver.
Not at all. That's a really crucial point that's become clear over the last decade or so. NAFLD isn't just confined to the liver, it has consequences throughout the body. It's recognized now as a multi-system disorder.
Okay, so what other systems are affected?
Well, one of the biggest ones is the cardiovascular system. People with NAFLD have significantly increased cardiovascular disease, CVD, mortality. In fact, CVD is often the leading cause of death in people with AFLD, sometimes even more common than liver-related death, especially in earlier stages.
Wow, so having fatty liver disease increases your risk of dying from heart attacks or strokes.
Substantially, yes. There's also a twofold increased risk of developing type 2 diabetes if you have AFLD. It's a bit of a two-way street. Diabetes drives ALD, and AFLD increases the risk of developing diabetes.
A vicious cycle. It can be. And then there's the link with chronic kidney disease, or CKD. And AFLD is associated with an increased risk of developing CKD as well.
Liver, heart, diabetes, kidneys, anything else?
Yes. The list keeps growing. It's also associated with conditions like osteoporosis, weakening of the bones, cholesterol, gallstones, an increased risk of colorectal cancers, sleep apnea, and polycystic ovary syndrome, PCOS, in women.
It really does touch almost every part of the body, doesn't it?
It seems to. The inflammation and metabolic dysfunction originating in the liver appear to have far-reaching systemic effects.
And thinking about the healthcare system impact, you mentioned liver cancer risk, but what about transplantation?
Yes. This is where the implications become really staggering, especially looking forward. NASH, that inflammatory form, is on a clear trajectory to become the most common reason for needing a liver transplant globally.
More common than hepatitis C or alcoholic liver disease?
It's already surpassed hepatitis C in the U.S. as an indication for transplant listing, and it's rapidly catching up to, or has possibly already overtaken, alcohol in some regions. In the U.S., back around the year 2000, NASH accounted for maybe 0.03% of liver transplants. By 2013, it was up to 26%.
That's an incredible increase in just over a decade.
It is. And this represents a huge, looming financial and resource burden. Liver transplants are incredibly expensive, require lifelong medication, and specialized teams. This is a massive challenge, especially, as we discussed, for resource-poor countries in Africa and the Middle East, where the infrastructure for transplantation might be limited or non-existent.
So the very regions seeing the fastest rise in NAFLD might be the least equipped to handle its most severe complication.
That's the harsh reality. And even for those who do get a transplant, it's not always a permanent fix for the underlying issue.
What do you mean?
There's a concerning recurrence rate of NASH in the transplanted liver, somewhere between 20% and 40%. The new liver can start accumulating fat and inflammation again because the underlying metabolic problems often persist.
Right. The transplant fixes the failed liver, but not necessarily the diabetes or obesity that caused it in the first place.
Exactly. It highlights the need to manage the whole metabolic picture, not just the liver damage.
Now, thinking specifically about Africa again, there's another major health challenge there. HIV. Is there any connection or interaction between NATIV and HIV?
Yes, and this is a really crucial and potentially growing issue for the Africa region, which, as you know, bears the highest burden of HIV infection globally.
So are people with HIV more likely to get NAFLD?
The data suggests yes. Studies, mostly from higher-income countries so far, indicate a high NAFLD prevalence in people living with HIV, particularly those on long-term antiretroviral therapy, or ART. Estimates are around 35%. A study in South Africa found a prevalence of 28% in people with HIV.
Why would that be? Is it the HIV itself or the treatment?
It's likely a combination of factors. Older generations of some antiretroviral drugs were known to cause metabolic changes, like body fat redistribution and lipid abnormalities that could contribute to NAFLD. Newer drugs are generally better, but long-term HIV infection itself might also play a role through chronic inflammation. Plus, people with HIV are living much longer now thanks to ART, so they are also experiencing the same age-related risks and lifestyle-related risks for NAFLD as the general population.
And ART access has expanded massively in Africa, right?
Massively. Initiatives like UNAIDS 90-90-90 targets led to huge scale-ups. Between 2010 and 2016 alone, over 10 million people gained access to art in Eastern and Southern Africa. This is a public health triumph.
Absolutely.
But it means we now have millions of people living long lives with HIV on treatment, and we urgently need to investigate the long-term implications of this art exposure alongside AG and lifestyle factors on NAFLD prevalence in these populations.
So it's like an intertwining of epidemics. The success in treating HIV might be unmasking or even contributing to a rise in non-communicable diseases like NAFLD within that same population.
That's the concern. It poses an added burden of chronic disease for people living with HIV and for the health systems caring for them. It's a complex interaction that we're only just beginning to really grapple with.
Okay, this has been a really comprehensive look at the scale, the drivers, and the far-reaching consequences of NAFLD. Given everything we've discussed, the silent nature, the rapid rise, the impact on multiple body systems, the transplant burden, the links with HIV, what's the bottom line? What needs to happen now? It feels like an urgent call to action is needed.
It absolutely is. There are several key takeaways and urgent needs. Firstly, as we highlighted, there's a significant unmet need for well-designed, population-based epidemiological studies, especially in Africa, to truly define the scope of the problem and the health service needs reliably. We can't fight what we can't accurately measure.
Right, get better data, especially in Africa.
And alongside that, we need more research to understand those intriguing racial and ethnic disparities and the precise role of body fat distribution. Why are some groups seemingly protected? Understanding that could offer clues for prevention or treatment for everyone.
Okay, more research. What about the immediate challenges for healthcare systems, particularly in Africa and the Middle East, where the burden is escalating?
The challenges are immense. As we said, there's a lack of cheap, specific, reliable tests for mass diagnosis and staging. Mass population screening is likely impractical and unaffordable in many low-resource settings right now.
So finding the people who need help early is hard.
Very hard. And then there's the sheer financial cost of managing the disease and its complications. Advanced liver disease, cirrhosis, cancer, and especially liver transplantation, these could easily overwhelm the healthcare budgets and capacity of many countries in these regions.
Not to mention the strain on personnel.
Exactly. There's often a shortage of specialized healthcare professionals, hepatologists, liver specialists, endocrinologists or diabetologists, dietitians, specialized radiologists or technologists. The rising tide of NAFLD will put immense pressure on these already limited resources.
So, faced with these challenges, what are the strategic responses? What can be done?
Health authorities in these high-burden regions really need to wake up to this silent threat now and start developing concrete strategies. It can't be ignored any longer.
What should those strategies include?
Well, first, actively working to document the extent of the disease within their own populations, prioritizing those epidemiological studies, maybe focusing first on high-risk groups like people with diabetes or obesity.
Know your enemy.
Precisely.
Right.
Second, adapting national health plans and policies to explicitly include NAFLD prevention and management. Third, and this is crucial, intensifying health education and public health awareness campaigns.
Why awareness so key?
Because right now, the primary and most effective treatment for NAFLD and NARUN is lifestyle modification specifically, weight reduction through diet and exercise. Public awareness is paramount for prevention and for motivating people towards healthier lifestyles.
So education is treatment in a way.
In large part, yes, currently.
Yeah.
Then there needs to be investment in training more of those specialized healthcare professionals we mentioned, diabetologists, hepatologists, dietitians, imaging specialists. Building capacity is essential.
And supporting research locally.
Yes, exploring scientific studies tailored to their own populations to understand local risk factors, disease progression, and effective interventions. And one final interesting strategic idea relates to the HIV link we discussed.
What's that?
Considering the integration of metabolic clinics, or NCD, non-communicable disease services, within existing, often well-established HIV care centers.
Leveraging the HIV infrastructure to tackle NAFLD and other metabolic issues in that population.
Exactly. It can be a very efficient way to screen, manage, and provide integrated care for this growing group facing dual burdens of infectious and non-communicable diseases. It's about being proactive and integrated in the approach.
That makes a lot of sense. So it's a multi-pronged approach.
Yeah.
Better data, policy changes, public awareness, workforce training, local research, and integrated care models.
That seems to be what's needed to start turning the tide against this silent epidemic.
Wow. Okay, we've really unpacked a lot there. We've seen how non-alcoholic fatty liver disease, NAFD, though often silent, often hidden, is undeniably a rapidly growing global health challenge. It's intensifying, particularly in Asia and the Middle East, driven by these huge waves of obesity and type 2 diabetes.
Yeah.
And the consequences, as we've heard, are far-reaching, affecting not just the liver, but cardiovascular health, kidney health, increasing cancer risk, straining healthcare systems, and potentially becoming the leading reason for liver transplants worldwide. It really is a hidden danger with massive implications.
It truly is. The silence of the disease belies the scale of the threat.
So, thinking about all this, what does it mean for you, our listener? Understanding NAFLD isn't just some abstract medical issue. It really serves as a window, doesn't it, into the deep interconnectedness of global health trends, modern lifestyles, economic development, and even social stability.
Absolutely. These things are all linked.
So as you reflect on this hidden danger we've explored today, maybe consider this. How might an informed awareness of these kinds of global health trends, even ones that seem distant like NAFLD hotspots in Asia or MENA, actually impact the communities where you live, or the decisions you make about health, or even just the conversations you have about global well-being and shared challenges? And perhaps thinking even more concretely, what's one small step maybe that you could take, inspired by this discussion, to support better health outcomes, whether that's locally or globally, for people facing this growing silent threat?
That's a great question to ponder. Awareness is the first step, always.